Welcome to The Deep Dive. Today we're tackling a condition that's maybe not widely known, but really interesting, effort thrombosis of the subclavian vein.
That's right. It's also called Paget-Schroeder syndrome.
Paget-Schroeder syndrome. And the surprising thing is it often hits people who are young, healthy, really active.
Exactly. It's kind of counterintuitive. And what we're really diving into today isn't just the condition itself, but the long-term picture. How do people do after treatment?
Right. And we're focusing on a specific, quite influential study from back in 2001. It looked at a pretty comprehensive way to treat this.
Yeah, a landmark paper, really. It evaluated a specific treatment algorithm.
Okay, so what did that involve? It sounds like multiple steps.
It did. It started with a thrombolysis using meds to dissolve the clot.
Okay, clot busting.
Then, right after, surgery. Thoracic Inlet Decompression, basically making more space for the vein.
Addressing the underlying squeeze makes sense.
Then, after that, they'd often widen the vein with a balloon. That's PTA, percutaneous transluminal angioplasty.
PTA, got it.
And for some patients, if the vein was still quite narrow, they'd put in a stent to keep it propped open.
So a whole sequence. Thrombolysis, surgery, PTA, maybe a stent.
Exactly. And the goal, the big question, was whether this whole approach could actually minimize long-term disability, those lingering symptoms.
Because the older ways of treating it,
Yeah.
they weren't always successful long-term, were they?
No, not at all. Before approaches like this became more standard, the sort of conservative treatments, rest, maybe some blood thinners, well, they often left people with significant issues. Pain, swelling, that kind of thing.
Okay, so let's back up just a tiny bit. Paget-Schroeder syndrome, what is it exactly? Why does it happen in these active people?
Well, like we said, it's effort thrombosis. So a blood clot forms in the subclavian vein, that main vein draining the arm, and it's triggered by, strenuous activity, repetitive arm movements, usually overhead stuff.
Like weightlifting or swimming, maybe?
Exactly, things like that. And it happens because the vein can get pinched in what's called the thoracic outlet. It's a tight spot between your collarbone and your first rib.
Mm-hmm.
So repetitive motion just compresses the vein over and over until, well, a clot forms. And it's usually young, fit people because they're the ones doing these activities.
Right, not the typical profile you might think of for a blood clot.
Yeah.
And those earlier treatments you mentioned, rest, elevation, anticoagulants. What were the main problems there? Why the need for something more?
Well, they dealt with the immediate clot, sure, prevented it maybe getting worse or traveling, but the underlying problem, that pinch point, it was still there.
Ah, okay.
So studies show, up to 75% of patients still had ongoing symptoms, arm pain, swelling, feeling heavy or tired, especially when they tried to use the arm.
Wow, 75%, that's huge. That must have been incredibly limiting for people wanting to get back to sports or work.
Definitely frustrating. So doctors started thinking, okay, we need to do more. The thinking evolved towards actually intervening.
What kind of interventions?
Things started moving towards staged approaches sometimes. So maybe anticoagulation first, then later surgery to fix the compression, usually taking out the first rib, actually, to create space.
Rib resection, okay.
Sometimes they try to physically remove the clot, too, thrombectomy. Or even though it was rarer, create a bypass around the blockage.
Okay.
But it was still a bit unclear, what's the best combination and when should you do each step?
Which leads us right back to this 2001 study. Kreinberg and colleagues publishing in the Journal of Vascular Surgery. This sounds like you tried to answer those timing and combination questions.
Precisely. It was a big deal because it looked at the long-term results of doing essentially everything in one go.
Yeah.
During a single hospital admission.
The whole sequence we talked about.
Yeah. Thrombolysis to bust the clot, then immediate surgery. In their case, it was a supraclavicular approach, so operating above the collarbone to decompress the vein, then the PTA ballooning, and then stenting only if there was still a significant narrowing left over.
Immediate surgery. That sounds like a key difference from maybe waiting weeks or months.
It was. That was part of the rationale they were testing.
So how did they set up the study? Who were the patients?
It was a retrospective look. They went back through the records of 23 patients they'd treated with this exact protocol between 1994 and 2000.
Okay.
And they followed up to see how things looked years later. What was the vein status? What were the symptoms like?
Got it. Any specifics on the timing within the protocol? Like how quickly did they start treatment?
Yeah, they noted that thrombolysis usually started pretty quickly after symptoms began, on average, around 9 days, give or take.
Okay, pretty responsive.
And the lysis itself took about 34 hours on average. Then, crucially, all patients went straight to that decompression surgery.
Right after lysis finished.
Yep. followed by the PTA for everyone. And then 14 of the 23 ended up needing a stent because they still had more than 50% narrowing after the ballooning.
14 out of 23 got stents.
Okay.
And how long was the follow-up?
It was pretty good. For the PTA-only group, the average follow-up was 4 years. For the stented group, it was about 3.5 years.
Okay, that gives us a decent long-term window. So the big reveal, what did they find? Let's start with the patients who didn't need a stent, just the PTA after lysis and surgery.
This is where the results were really quite impressive. For those patients, the ones treated with PTA alone, every single one of them, their vein was still open at that 4-year follow-up mark.
100% patency.
100%. And just as importantly, they reported being able to get back to all their previous activities, work, recreation, no limitations.
Wow. That's a fantastic outcome. It really suggests that fixing the compression and clearing the clot, then just ensuring the vein is reasonably open with a balloon can be enough for many people.
It certainly looked that way in this group, a real win for that part of the algorithm.
Okay, now what about the 14 patients who did get stents? How did they fare?
Well, the picture there was a bit more mixed.
Okay.
So in that group, 9 out of the 14 veins were still patent at the 3.5-year follow-up.
So about 64% patency. Still decent, but definitely not the 100% seen in the PTA-only group.
Right. There were failures. And the timing of those failures was interesting.
How so?
2 of the stents blocked up very early, like within 2 days.
Well, okay.
Then another 2 failed around the 1-year mark. And the rest, 7 of them, occluded later, around 3 years out.
That pattern, early failures versus later ones.
Yeah.
Did they figure out why? Was there a difference?
They did, and this is really key. They found a couple of factors seemed linked specifically to those early stent failures.
Okay, what were they?
First, if the original blood clot wasn't just in the subclavian vein, but had actually extended further down the arm into the brachial vein, those stents were more likely to thrombose, to clot off quickly.
So more extensive clot burden was a risk factor for early stent failure. Makes sense. What was the second factor?
This was a big one. They discovered that factor V Leiden, a genetic condition that makes your blood clot more easily, was present in 3 patients. And those patients included the ones with the early stent failures.
Factor V Leiden. So an underlying hypercoagulable state.
Exactly. It really drove home that it's not just about the plumbing, the anatomy. The patient's inherent tendency to clot plays a huge role, especially when you're putting foreign material like a stent into a vein.
That's a critical finding.
Yeah.
It suggests you really need to know about these underlying conditions.
Yeah.
Did they mention any other issues in the stented group?
They did note that 3 patients in the stented group reported having to make major changes to their recreational activities.
Why was that? Still symptoms.
Not necessarily symptoms from the vein itself, but they felt it was mainly because they needed to stay on long-term anticoagulation, blood thinners, because of the stent. And that carries bleeding risks, right? So certain activities might become too risky.
Right. The treatment itself having an impact on lifestyle. Okay, so taking all this and the great results with PTA alone, the more complex picture with stents, the factor V Leiden link, what did the authors conclude? What were their main takeaways back in 2001?
Well, a big point was just validating this whole comprehensive approach long-term, providing that evidence. They really argued for the single admission protocol.
Doing it all at once.
Yeah, their reasoning was that getting the decompression done immediately after thrombolysis could prevent the vein from scarring down and narrowing again, which might happen if you waited weeks or months for the surgery. Faster resolution, potentially better vein quality long-term.
That makes logical sense. Fix the problem before chronic changes set in. Did they identify any patient groups where this approach maybe didn't work as well?
They did mention that. They observed that patients who came in with really long segments of the vein already completely blocked by chronic clot, they didn't seem to respond as well. These were often the ones needing extensive stenting, and as we saw, those stents had a higher risk of failing, especially early on. So maybe a different strategy is needed for those really extensive cases.
And that factor V Leiden finding, did that change practice?
Oh, absolutely. That was a major implication. The authors strongly recommended that testing for hypercoagulable states like factor V Leiden should become a standard part of the workup for anyone presenting with Paget-Schroeder.
So you know up front if someone has that increased clotting risk.
Exactly. It helps you tailor the treatment. Maybe they need a longer course of anticoagulation, or maybe you'd be even more hesitant to place a stent if you could avoid it. That definitely became much more common practice after this paper.
It really shows how one study can ripple outwards. Now that was 2001. We're talking over 2 decades ago. What's changed since then? Did the authors even hint at future directions?
They did, actually. In their discussion, they touched on things that were emerging then and are much more common now, like mechanical thrombectomy devices.
Instead of just relying on the clot-busting drugs.
Right. Devices like angiojet or the penumbra indigo system, they're essentially little devices that can go into the vein and physically remove or suck out the clot.
Like a vacuum cleaner for the vein?
Sort of, yeah. And the potential benefit is using less of the planolytic drug, or maybe needing it for a shorter time. That could mean lower bleeding risks for the patient.
That sounds like a significant advance.
Yeah.
What about the surgery itself, the decompression? Any evolution there?
Yes. There's been a noticeable shift towards using an infraclavicular approach for the first rib resection.
So operating from below the collarbone instead of above, like in the study.
Exactly. The rationale is that going from below might carry a lower risk of injuring the brachial plexus, those important arm nerves that run nearby. It's a known, though thankfully uncommon, risk with the supraclavicular approach. So many surgeons prefer the infraclavicular route now for potentially better nerve safety.
Interesting. Refining the techniques for safety, did the authors comment on the patients they were seeing? Any changes even back then?
They did mention seeing, anecdotally, more referrals for this venous thoracic outlet syndrome, and the patients seemed to be getting younger and were generally more active.
Why do you think that was?
They speculated it might just be increased awareness. Primary care docs, ER docs, maybe recognizing the symptoms earlier and sending people to specialists sooner.
Makes sense. Better awareness leads to earlier diagnosis. So, okay, let's bring it back to the study's core conclusions from 2001. What was the final word from Kreinberg and colleagues?
Their main message was pretty clear. Early surgery right after thrombolysis to fix the compression is safe and it works well for effort thrombosis.
Thumbs up for early intervention.
Definitely. And they highlighted the really excellent long-term results, patency, and symptom relief achieved with just balloon angioplasty after that rib resection.
100% group.
Exactly. But they also provided reassurance that for those patients who do have short bits of significant narrowing left after PTA, putting in a stent can be a reasonable option, likely to provide good long-term patency, especially if you've ruled out or appropriately managed any underlying clotting disorders.
So selective stenting. Not for everyone, but useful in the right context.
That sums it up well.
Okay, so wrapping up our deep dive today. This 2001 paper really seems to have solidified a treatment pathway for Paget-Schroeder. It gave solid long-term data backing up that multi-step approach. Act early, deal with the clot, deal with the compression, widen the vein, and use stents judiciously, paying close attention to clotting risk factors.
Absolutely. It provided crucial evidence, and its influence is clear in how practice evolved, the routine hypercoagulable workups, the move towards newer thrombectomy methods and refined surgical approaches. It laid a really important foundation.
It really did. A fascinating look back at how medical understanding progresses. So here's a final thought for you, our listeners, to chew on. Considering the advancements since 2001, those mechanical thrombectomy devices, the different surgical approaches, if we were to repeat a long-term study like this today, what might we find? What would the optimal strategy look like now? And how much further could personalized medicine, really tailoring the approach based on individual risk factors, take us in managing Paget-Schroeder for active people?
Great questions to ponder.
Thanks for joining us for this deep dive.